session as folks are chiming. So welcome to this echo session today. As folks chime on, we'll wait a few seconds. Today's echo session is on health workforce, how to address the bottlenecks. Great. Today we will have interpretation. I can't read my screen. All right, today we'll have interpretation in French and Spanish. It's available by clicking the interpretation button, which you see a screenshot here. Click on interpretation and choose the language you like to hear. Next slide, please. We also have two features to facilitate the conversation today. Please use the Q&A feature for questions regarding the topic question, and please use the chat feature regarding IT logistics or certification of attendance. You see an example screenshot here. Next slide. In order to see live transcription, click on live transcript and choose show subtitle. The caption would appear on the screen. To close the caption, click the hide subtitle button, as you can see in these screenshots here. Good morning. Next slide, please. Next slide, please. We will have certificates of, this session is being recorded. Your attendance is consent to be recorded. Recordings will be shared after the session in English, French, and Spanish. A certificate of attendance will also be available through the University of Mexico via a link in the chat at the end of the session. We often get questions on this, and so the link will be sent at the end of the session today. Next slide. We take data use quite seriously. Project ECHO collects registration, participation data, questions and answers, chat comments, and poll responses for some ECHO programs. Your personally identifiable information will be shared with the project funder, and the data may be used for reports, maps, communication surveys, quality assurance, evaluation research to inform new initiatives. Next slide. Why don't we go ahead and start today? Let me introduce you to our moderator for announcements, the agenda, learning objectives. Patrick, the floor is yours.
Thank you very much, Angela. And
thank you.
Good morning, good afternoon, good evening, everybody. Welcome to this ECHO session. It is my pleasure to moderate it. My name is Patrick Zuber, and I work with the Deputy Director General of WHO on health systems issue related to the response to COVID-19. Can I have the next slide, please? So today we have a very exciting lineup of presenters. This is a session on health workforce to address the bottlenecks. You have the program for the upcoming sessions for the next month and a half until the 15th December with vaccination financing in Southeast Asia next week. Then COVID-19 and COVAX data. 8th of December, COVID-19 vaccine impact modeling, and on the 15th of December, global status update. Next slide, please. Yes, so we have a very exciting lineup of speakers today who will be discussing identifying the human resource requirement for COVID-19 vaccines deployment. We're going to have a country presentation from Romania. We are going to have the perspective from civil society in a country which faces lots of difficulty, Lebanon, and we'll see how public financial management can help. Next slide, please. So the goal and learning objectives of the session is to highlight the need for countries to revise NDVPs and to ensure the necessary human and financial resources to roll out COVID-19 vaccines. Learning objectives being to understand how to calculate health workers' needs, learn about options to recruit, support, and pay additional health workers, understand how countries are balancing the need to roll out vaccines quickly against equally critical COVID-19 response requirement for diagnosis and treatment, and maintaining essential health services. To learn about potential sources to increase the quantity of trained health workers to support rollout, including civil society organizations like the Red Crescent Movement, and to understand some options and strategies for public financial management that are needed to support human resources for COVID-19 vaccines rollout. Next. So without further ado, it is my pleasure to introduce two colleagues from WHO headquarters, Amani Siam and Catherine Kane from the Health Workforce Department in Geneva. And the floor is yours.
Thank you very much. Thank you, Patrick, and hello, everyone. May I just confirm you are able to hear me? Yeah?
Yes, we are. Loud and clear.
Thank you very much. I'll just temporarily go off camera just to be able to focus on the bigger screen with my presentation. So I think the background, as Angela said at the beginning of this session, we are purely a data-driven approach to understanding the health workforce requirements for COVID-19 vaccines rollout. Next slide, please. So I'm going to give you a rapid overview of exactly what is to be expected in the coming sort of 1 hour. So overall, we are going to have a brief overview of the common situation that you are familiar with on the global inequities in the human resource for health distribution. And we will move forward to understand how is that going to be handled within the context of a very big vaccination program that is rolling out at a very high speed. What are the HRH surge requirements and some sort of reflections on the vaccine equity. And with that, we want to highlight a key concern of ours on the coverage of health workers by the vaccination rollout itself. And then we are going to spot check on a few things like the HRH management support, the modalities for recruitment, the deployment and remuneration. And we have two sterling examples from Romania and Lebanon, where you will hear firsthand from the high-level individuals who are handling the situation on the ground. And then in a final presentation, you will get a glimpse of the financing implications and opportunities, specifically focused around public finance management systems. Please forward, next slide, please. So the global health workforce situation, I think for many of you, it's an age-old problem that you are familiar with. All parts of the globe, all countries have a certain degree of a health workforce shortage, and that has existed pre-COVID. It got exacerbated as the onset situation happened with COVID a year ago, or about 18 months ago. And over and above the existing shortages, we were witnessing reports of course, as you can imagine, health workers being infected and some of them unfortunately losing their lives. The work situation was quite difficult, and then you can see that there were some disputes or strikes or some sort of people giving up at all coming to work because of the immediate stress related to service provision. And put together, we can see that there are many, many implications to this situation, and a few are listed in that infographic you have to the left side. To the right side is, as Angela said at the beginning of the session, we are the data-driven approach to understanding what are the implications, and we are driven by two important monitoring mechanisms, looking at, for instance, the Universal Health Coverage Index, as well as the density of health and care workers that we are familiar with. And just to give you an idea, in the lower income countries, you have the target population of about 41%, 4 in 10 individuals are living in the lower income countries, where only 17% of the health workforce global is found, compared to the high income countries, who are like 14% of the global population, whilst they hold together almost 4 in 10 of the existing health workforce. And they, of course, enjoy the higher indices of UHC. The lower middle incomes are in between. And these are the two parameters that will probably be determining what you will see in the coming slides. Forward, please. Thank you. So we are handling all of us together as one international community, the biggest vaccination program in the history of public health that is rolling out at the fastest time frame possible. And in the most recent global strategy launched by WHO, the targets are quite high, 10% in the first 9 months, followed by 40% by the end of 2021 to 70% by June 2022. Definitely, as you can imagine, we need to understand the human and financial resources needed. We have to understand what sort of strategies have to be rapidly absorbed and devised so that we can meet all the rapid deployment, the target coverage, the equity. And of course, we want to do this in the most efficient way by reducing vaccine wastage and at the same time deliver quality and quantity and the HR research capacity that should be a credulous one for countries to start planning for. Forward, please. Next slide. So this is the bit of science that you just need to consider. We're looking at the situation of the surge, the planning for what's needed and where and when. And as I said at the beginning, the two parameters or the two dimensions we're looking at is they are more or less gauged by the UHC service coverage index and what is known about the density of health and care workers per 10,000 population. And this is an approximate situation by which we can determine where the most needed surge will have to happen. So the countries you are seeing, the red bubbles, are those countries who are sitting below a 50% service coverage index on UHC and a deterministic threshold of 48.5 health and care workers per 10,000 population. For those countries, we would need a full scale up of their health workforce, in the sense that that has to be determined, well, we will see it later, by the needs approach that we will use. But this is almost a protective measure so that we would reduce the existing disruptions that have happened because of the COVID response and the shortages that are long established. The bubbles in the sort of the pale green to whatever brownish color, these are the ones who will need a partial scale up, where we know their existing service coverage index is somewhere to closer to between 50 and 80%. And then the ones that we feel will be able to deal with the existing workforce for the vaccine deployments are the ones that you are seeing in the tiny blues. And even for those, the wisdom that we have to say about this, we do know even the high income countries, those that we seem to think will not need a serious scale up, they're actually already deploying a bigger number of health and care workers outside their existing healthcare system so that to be able to cope with the rapid vaccination rollout. Next slide, please. So this bit, you don't have to worry about understanding maybe all the direct elements, but it's a very simplistic, straightforward approach. It has a step one where we need to understand the population size to be covered, the number of doses as per the vaccine regimen. In step two, we do have to have some workload key elements to be understood. For instance, the time that's available per health worker, per week, per day, and at the same time, the team compositions that are needed, and at the same moment of time, the time scale that, or at least the time spot that would be needed to administer vaccines. And then using those two key components of step one and step two, we can actually determine a workforce-based need that is explained but in two components by what does it, how many health workforce exist, and what is the corresponding gap that would need the actual scale-up element to happen. The methodology of this calculation will feature in a paper that we are currently preparing, and it's about to be sent for peer review and for full publication with the help of our colleagues from the IVB department and the HDF department. And of course, that being said, in step 5, once that need is understood and the gap is understood, the corresponding costing is actually produced, and with it some sort of estimation that can then go forward to be thought about for the financing part. Forward, please. Next slide. So just to give you an example. So for instance, if you're looking for the rapid requirement or the surge needed to cover 10% of the population, You can see that there will be 3 components calculated. The first component is the direct individuals, the vaccinators and the supervisors who are actually involved immediately in the care provision for vaccines. You have a support staff that come with them. And of course, a community mobilizer or individuals who will be involved in raising the awareness and bringing people to be vaccinated or to be reached. So for that, for example, for a 10% coverage of the global population, we are estimating 643 FTEs, full-time equivalents, will be needed to do that, meaning 100% work only on the vaccination side. Given what we know from who exists on the ground, we can see that a third of that number will have to be additional staff, 220,900. And if you look at the right side, you will actually see the distribution of that need. It mostly exists in the lower income countries. That's why you have the big blue bar. And at the same time, the scale up is correspondingly exactly there. It's actually also on the right side, in the blue side, relevant to the LICs. Remember what I told you earlier, that the LICs are almost 40% of the global target that you need to have covered. Next slide, please. Having these kind of calculations, we actually can show you what's the time, what's the actual need and the scale up corresponding to it to cover the 10%. This is in tandem with the global strategy, the 40% and the corresponding 70%. And of course, as you can see, the shorter the time period we are running after, the higher the need estimate and the higher the scale up corresponding to it. And I'm just going to move a little bit this so that I can show, and you can see on the costing side, you have the corresponding wage bill, of course, because here we are looking at salaries of those additional staff. And you can see that, for instance, for the 40% by the end of 2020, we're looking at a bill of about $6.6 billion US dollars. For the 70%, it tops up to about $12.28 billion dollars. Next slide, please. Of course, this is borrowed from a presentation that you saw from Anne Lindstrom, and that was done in, I think, around mid-August. And as you can imagine, the kind of impetus, the kind of momentum that would be needed, especially in the fourth quarter of 2021. The records tell us that this is to administer such vaccine. This is like a 4.5 times those administered on the routine system compared to the Q4 of 2019. And most importantly, the surge, the health system has to cope with a considerable increase in the available sort of capacity, which is almost 2 times that was used or 2 times that was observed in Q3 of 2021. And of course, this is, in my view, a best case scenario where countries could be encouraged to maintain momentum and even think in a concerted way of how that momentum could actually be boosted up in the remaining 3 months, or at least less than 2 months now to the end of the year. Next slide, please. So this is now a glimpse that you need to understand also about the issues around the coverage, health workers who are covered by vaccines themselves. Why are we putting that in? This is a core business for us. The protection of the health and care workers is something that has been highly called for this year being the year of the health and care workers. There's a campaign going on. It puts the appreciation and recognition of the health workers' effort in this exceptional time at forefront. And what we can see is that there is a considerable pace being made, especially in Q3, in vaccinating health workers. We think in about 122 countries. We know that 103 million doses were provided to healthcare workers, but this is still suboptimal. We still think that there should be more of an effort made to pump up that number. We think around 55.4 million are the number of healthcare workers in these countries, and we think about 40% of them have been vaccinated. And we aim for more because we still think about 78.6 million health workers in about 72 countries are still with a vaccination status unknown. So I think this is just for you to have an idea about the situation with the health workers themselves and their own protection and coverage. Moving forward, please, next slide. WHO has done quite a bit in this area. For instance, we have launched very critical guidance on the understanding of the HRH management support. It has been out there since about the early part of 2021. And in it, there are some sort of key interventions and recommendations to support the vaccination team, the vaccination teams in the competency-based training, supporting the supervision, the handling of the supply chain. And this is definitely a big showcase of where the most investments are needed to support the existing and to be hired health workforce. Forward, please. Next slide. The labor resources. This is a big dilemma, of course, in many countries. Some countries do enjoy a sort of a surplus labor that due to availability of workers, either through hiring of individuals who are inside the country or even outside the country. And in some countries, we do know that there's a considerable number of health workers who are not in full employment, and there could be possibilities to bring those on board for this big deployment. So you have retired medical staff, or the worry that we have is the redeployment of active health workers. This is for us, as you can imagine, has a tendency to weaken systems. But that's why in this presentation and today, you will hear from the country examples, the role played by the CSOs and INGOs in actually supporting this huge endeavor. The private sector, of course, has its role. And there are a lot of mechanisms that have put forward all the resources that can come forward, clinical, non-clinical, to support the big size up of this campaign. Forward, please, next slide. We're also, I think, guidance was also developed to support our regional and country offices in putting synopses of the planning considerations to be made, everything from the staffing element to the recruitment element and to the deployment. And I think this is something that will be very helpful to staff on the ground, to all of you working and facing all of these policy making opportunities that you have. And in it, there will be a synopsis of all what you've heard today, the understanding of how the surge has been calculated and other elements of the competencies and the skills needed to increase the available staff expertise, and at the same time get them to be on the ground and operative as quickly as can be. Forward, please. I will stop. I don't want to take too much on this because we are lucky that our speaker in this session will be able to tell you a lot more about the financial implications and opportunities. And I just feel that this is an important entry point to consider. How do you actually deal with the requirements, both for the surge? And for me, a most important message that I would leave you with is that that surge capacity needs to be sustained for a while to come. This is not a one-stop shop or a silver bullet. The fact that staff have to be hired, trained, skilled up, supported, to work in a decent environment and carrying forward to a period that is, yes, we are thinking of the next 18 months, but this has to also forge out a sustainable solution for the years to come. Thank you very much, and back to you, Patrick.
Thank you very much, Amani. This was a very clear presentation, and I'm sure everybody was extremely interested with it. We have about 7-8 minutes for a question and answer session to you. And maybe I'll start this session by just asking you, how is WHO supporting countries to do the needs estimates at country level? Is this already included in the vaccine deployment process, or is this something additional which is being done? And also, how does it work in very large countries that have very diverse situations? Over to you.
Thank you, Patrick. I may have sort of slipped the chance to mention this in one of the slides. So basically, what we have done is we have integrated the same methodology in the civic tool. And I hope, of course, I'm speaking to an audience who are familiar with the costing tool. And in it, the method is quite agile. It actually allows the calculation of different claim formations by types of sites, whether they are mobile sites or fixed sites. And with it, there could be the flexibility to actually vary the mix even subnationally or at the national level. And as you have seen from the calculations, it's an FTE calculation. So in the end, the country can actually determine the FTE, but decide to split the formation or the combination of who should be working at what rate, 100%, 50%, 30%. Accordingly, the most important thing is that they would have a full realization of the estimated scale up needed and the costing to go with it. How are we supporting this? I think we have been present in all sort of queries that have come about the health workforce, because we've noticed that even the national, the MVDPs that were submitted through an analysis that we've done, is that there has been a bit of an ad hoc estimation on the health workforce requirements. So through our work with the country offices and the regions, and we have ongoing case studies, we're trying to transmit a bit of the science and the calculations that you have seen, more or less a methodology that people are familiar with on the ground. It's called the workload indicators for staffing needs, to show them that this is a simple calculation. It doesn't involve any tough modeling. It's just a range of inputs that can be adjusted according to the country setup and the service delivery model, as I said, whether it's a fixed site or a mobile site or a full-fledged campaign flow approach. Thank you, Patrick.
Thank you, Amani. The floor is open. Are there other questions for Amani?
So Patrick, it's not an open mic situation, and so you have to take a look into the chat box and call the questions.
Sorry.
Q&A box and call the questions. So just to let you know that they, it's not set up in that way to be able to. So it looks like there's a few there. If you can pick up some of those strands, and then
Yes.
for the participants, if you could please use the Q&A function, as we noted earlier, it would be super helpful. So perhaps transfer some of those questions over. We can do that. Louis, if you can do that, then Patrick, you can call from those two buckets. But largely the Q&A and the chat box looks like there's a few things in there.
Thank you very much.
Patrick, this is Catherine. I do see another one that seems to me would be for Amani. The models are very useful and good start for estimations. How does it account for the fact that these are the same workers who have to deal with the surge in COVID care? Can the current caseload be added to the tool? And then there's a second part to this, which is, sorry about that. There we go. Let's start with that one.
Okay, so let's go with the one on the caseload. So the way this calculation has been done, as I said from the start, is that this is net of the existing service provision and the existing caseload, in the way that we cannot put in an extra caseload through outpatient, say, visits or any extra calcul within the same arithmetic calculation of the surge. The reason being is that of what the justification that we've made at the beginning. We are assuming that is a new role that has to be planned for over and above the existing role that the health system is providing. And this is simply because of the time scale and the immediate workload of the population to be covered. This is almost an initiated service provision that has never been factored to this scale and this sort of time scale and size in any of the plans that countries have in place, of the health system's national plans. And this is in its own right a safeguard, given that we do know that at least 2/3 of countries reporting on service disruptions have said that health workforce shortage or lack of availability is one of the key reasons of the disruptions. And I think with that sort of thinking in mind, we have to maintain this as the future forward, that insofar as the requirements of immunization, at least vaccination of COVID-19, they have to be thought of as a new stream of work added to the existing service provision. Thank you.
Very good. So we'll take just one more question. It's from David Bryden, and regarding the costing on slide 19, when does this time scale start? Beginning of 2021 or later on?
That is a very smart question. So I think when we were doing this calculation, the supposition is that we are having, when we say a 9 months period, the 12 months period of 2021 and the 18 months period until mid 2022, we just juxtapose that against the global strategy, or at least the strategy of achieving those targets. But you are absolutely right. The duration or the start point will probably not be a common start point for all countries, but this is again just exemplifying how we can actually size the need and size the relative costing that's needed both at the global level and also at the national level. And I think the difficulty we have is that we all know vaccines are still not at full availability in every country. And of course, the vaccination rollout is also picking up slowly. So from a comparative point of view, we are assuming it's a 9 months period within a 9 month start period from the beginning of 2021 to the end period of 12 months by the end of 2021, and then the 6 months following to 2022.
Thank you very much, Amani. We will now move to the next presentation, which is a presentation about the country experience from Romania. And we are very privileged to have with us today Dr. Red Arafat, who is the Secretary of State, Head of Department for Emergency Situations in Romania. Dr. Arafat, the floor is yours.
Hello, thank you very much, and I'm honored to be invited by you. What I want to share in our experience is how we got to aggravate our shortage of health workforce in the last years, and what did we do to manage the situation of the COVID-19, not necessarily the vaccination, but all the response issues. As you know, Romania now is facing the hardest wave we ever had because of the vaccination hesitancy. We have only less than 40%, around 40% of the population vaccinated because of a heavy anti-vaccination propaganda. After, at the beginning, Romania was really evolving well. But during this wave and the previous wave, we had to take some measures in order to improve our capacity to deal with the COVID patients, especially with the critical ones. So I want to go in the history of our country in 2011, where 2010, 2011, it was the economical crisis then, if everybody can remember that. And we had the IMF visiting us, and all the thoughts were on how to reduce the public expenditure. So at a certain moment, there was a decision. I was at that time Understate Secretary at the Ministry of Health. And I remember the discussions we had with the highest levels in the country, and with the IMF and with everyone, explaining to them that we cannot work on reducing the human resources costs in the health sector when the health sector is lacking human resources. Still, on one day, a major decision was taken in the country, and a drop of all public services salaries by 25% overnight was done. So young doctors, nurses, and so on found their salaries, which were anyhow very low at that time, reduced by 25%. That was the trigger to the biggest migration of physicians and nurses, especially the young residents and specialists, to other countries in Europe. And we lost a huge number of emergency physicians, anesthesia and critical care physicians, radiologists, obstetricians, and so on, especially the young ones which had loans from their banks and so on. There was no protection for them. So the decision was to leave the country and to go work somewhere else. Now, during this COVID crisis, we felt very well the loss we had 10 years ago, because those should have been now the main core of workers in the healthcare system for the specialties that I mentioned. But we feel that, and we felt very well that there was a gap, and that gap was pushed a lot during the economical crisis because nobody wanted to think of the impact on a medium or long term. Everybody was thinking only on how to reduce costs without thinking that any measure could lead to a long-term disaster in the health sector and to the reduction of the human resources for a long term, which is very hard to recover. So this is one issue. Also, Romania was losing anyhow part of its health sector personnel because of the low salaries at that time. So even now, 2 years ago, we increased significantly the salaries. We are not able to recover those who left Romania. They already have families, they have their children in schools and so on, where they left, so they are not coming back. So now with the COVID-19, how did we find solutions? What we faced was that we needed to increase the number of intensive care beds. We needed to increase the capacities in the emergency departments. In the intensive care beds needed to be increased when anyhow the intensive care departments, most of them suffer from shortage of personnel. So we took some measures by law, and it helped that in Romania, the whole coordination of the response to the pandemic is a national one. And the Department for Emergency Situations, which includes the civil protection and the emergency medical response, is under the Ministry of Interior. So together with the Ministry of Health and with the Ministry of Defense, we started working at a national level to improve the situation and to increase the capacity. But how can you increase the capacity if you don't have the personnel to hire? There was no way to move people from one hospital to the other for the COVID by hiring them from one place and to the other and creating a deficiency in the initial place where they were working. So what we did, we created a mechanism of what we call it detachment or secondment of physicians and nurses from those hospitals which were not involved in COVID, or those hospitals which had sufficient physicians. For example, an intensive care department which had 15 physicians, we decided to take 5 and send them to another hospital which had only 3 physicians, so that we can ensure there is a continuous shift and we can increase the number of beds. Same thing for nurses. This was done based on the law because we are in a state of alert. And this was done by order of the head of the Department for Emergency Situations based on the request from the health departments in the country. In each county, we have a health department, or the request from the hospitals in each county. We moved in the period, and I'm going to give you the numbers now. We moved from the beginning of this pandemic until now. We succeeded to move a number of 9,190 physicians, 5,539 nurses, and 1,737 other categories of personnel between hospitals. Of course, the numbers may include persons which were moved several times, but still we are talking about nearly 16,000 people moved from the beginning of the pandemic. Only since the last wave, we moved 705 physicians, specialists in different fields, and 700 nurses and 595 from other categories. So these are the people that we found that we could move them from a certain health entity to the other. The law says that we can move them for 1 month, they cannot refuse, and the managers of the hospitals cannot decide against our decision. We pay them more when we move them. We pay them 50% of their salary more, and we ensure they have the accommodation and everything insured by the health facility where they are moving. So they have a hotel room and so on, paid by the entity which is benefiting from them. This way, we succeeded to increase our intensive care beds to a number of around 1,800 or 1,700, when at the beginning they were mostly 1,200 beds dedicated for the COVID patients. At the same time, we created field hospitals. We used the military. So we brought the military in and we created field hospitals, out of which 4 are functioning at this moment within this wave. And we are using also military personnel and military medical personnel. Another category of personnel we used were the residents, especially the residents in emergency medicine, intensive care and anesthesia, and infectious disease and internal medicine disease. So we interrupted their training and we moved them to their basic specialty departments where they could practice their basic specialty, where they are training under supervision. So we could increase by hundreds of physicians by just moving the residents from different specialties. And we moved them also from one city to the other, from one end of the country to the other, without any hesitancy from this point of view. We also did one more step because of the shortage of the nurses. What we did is to establish by law that during the state of alert, medical students in their last 2 years are equal to registered nurses, and that they can be sent as volunteers to work in hospitals, because when we wanted to send them as volunteers, the hospital management, the legal services were refusing to use them, though they were lacking personnel. So we said that they are considered as registered personnel, and then we said they can be used within the hospitals as nurses to help the registered nurses which are in the hospitals. And for this, we moved around 2,000 medical students in cooperation with the medical universities. And we still, at this moment, have a few hundreds of them that are being used in different hospitals to work as a supplementary personnel, as nursing personnel in these hospitals. So what we are learning from this experience in Romania is that our planning failed, and that previous decisions led us to where we are now. I think that one of the things we need to start thinking of is the way we staff our hospitals and the way we think of our hospitals. The mistake we were doing is that when a hospital was 95% occupancy, had a 95% occupancy, everybody was saying, that is an excellent hospital. It has 95% occupancy. Then COVID came and we found that we don't have %, occupancy as a good sign. We need a surge capacity. So maybe we need to have redundancies, and we need to create redundancies in the hospitals. The other point regarding the human resources is that we hire people as much as we need for our current daily activity, including in the services which are the main services to answer to disasters, whether it's a pandemic, whether it's an earthquake or a multi-trauma incident. When we are hiring our people, the intensive care personnel, they are usually for the daily work. We don't think that this intensive care department may need to be increased by double, and we need to increase the number of beds within the next 2 days, and we need the personnel to serve them. So the way we think in the hospitals at this moment, I think needs again to be analyzed, because we think in a business concept that is to yield the best from the money we have, and to get the most of what we are doing as a revenue, and not spending much money on the redundancies and on the reserves that we need. And I think that here we need to start thinking of this, and maybe there needs to be solutions so that especially the hospitals, which will be the frontline hospitals, they need to have redundancies, they need to have backups, and they need to have this all the time, not only when a disaster builds up. So this is what I can share with you. We are learning a lot from this pandemic. We succeeded to find solutions for the moment. It was not easy. Not everybody accepted the secondment to other hospitals. Some of our colleagues went to courts to attack us why we are sending them. Some of them lost, some of them won, but others accepted the idea and knew that they had to go because they are needed, and we are in the mid of long-term disaster. So this is what I can share at this moment. I'm happy to answer any question before I leave you. Thank you.
Thank you very much, Dr. Arafat. That was really extremely convincing example of the challenges of health workforce. I have a first question for you. Since you were in a situation of relatively constrained health workforce, getting a surge was probably also limited by the various options that you have mentioned. Did you adjust your immunization coverage objective or the, let's say, the timeline to reach those immunization targets according to the surge capacity? And is this possibly also an explanation for the relatively low coverage you have?
Very good question. We separated the immunization from the treatment and the fight against the COVID impact. The immunization, we gave it to the Ministry of Defense to organize it. Together with the Ministry of Health and ourselves, we were supporting them. And we dealt with the impact and with what needs to be done in the hospitals. So the personnel for the immunization, we used nurses, we used GPs, we used different categories of personnel that we could mobilize for the immunization center. So there was no delay in the immunization. And also, at least myself, I was suggesting that we think out of the box. To inject the vaccine, you don't need the professor there. You don't need a doctor. You can do it by a nurse. You can do it by a paramedic, which is trained. And this is what we did. Whilst in the intensive care departments, in the emergency departments and so on, where we had lack of personnel, we moved personnel between hospitals, as I told you. So the Ministry of Defense put a lot of their human resources in the vaccination campaign, which helped that this vaccination campaign works besides the work we are doing against the COVID impact in the hospitals.
Thank you very much. Can you tell us how many staff you have in your immunization teams?
I don't have the number, but I can tell you that we have the capacity to immunize about 100,000 people a day.
100,000 people a day?
Yes, per day. And this number, we had it. We went up to it a few days ago again, because people saw the impact of this wave. So we had up to 98,000 in one day, first dose, and another about 30,000 second dose and third dose. So it was even beyond 100,000. But now the number is decreasing because the campaign against vaccination also steamed up and they started attacking again. So we are trying to work this. We in fact have now a team from the WHO that is discussing with everyone to see what are the solutions we find. But the capacity to vaccinate per day, it easily can do 100,000 or more per day.
Thank you very much. We have a final question for you. How did you secure additional fiscal space for those additional surge employment and allowances?
We did two things. First of all, in the emergency departments, we extended them outside and inside. Outside, we put modular structures for them, and inside, we occupied spaces that were not occupied initially by the emergency department. In the intensive care units, we looked at hospitals which had places with oxygen outlets and electricity, and we transformed simple internal medicine beds or something like this into intensive care beds. We created a national strategic stockpile, ventilators, injection pumps, monitors, and so on. And we started distributing them to the hospitals, which could increase their capacity. So the space was found in the hospital, but of course, it is on the expense of the daily care of non-critical patients. Because when you have a wave like this, at the end, you are forced to reduce the current care of non-urgent cases that can be postponed in order to deal with the disaster. So this is how we increased the surge. Plus, we had the 4 field hospitals I talked about, and we also are using 5 mobile intensive care units, which are on trailers that we connect them to hospitals, and each one has 12-bed intensive care units in it.
Okay, and I think the part of the question was about the financial space. Did you did you increase the budget? Did you take from
Yes.
other government sectors?
Yes, 100%. We increased the budget. The Prime Minister and the Minister of Finance gave us all what was needed for these modifications and the urgent purchases of equipment for our stockpiles and the materials and the PPEs and so on. So definitely the budget was increased in the last period.
Thank you very much. Dr. Arafat, that was a very interesting presentation and certainly presented by someone who has gone through the whole exercise and led the process. So thank you very much for your testimony.
Thank you. I'm sorry I have to leave you because we are in the midst of evacuating some patients to Germany. So thank you very much for having me on this meeting. Thank you.
Very good. May I check if Dr. Nasser is online? Yes, I can see you. Our next presenter, Dr. Anthony Nasser from the Red Cross in Lebanon, is going to present the civil society perspective. Dr. Nasser, over to you.
Yes, good afternoon, and thank you for the invitation. I'm very glad to be among you. Thanks a lot. I'm gonna just present 2 minutes about how was the Lebanese Red Cross response toward COVID-19 pandemic. Next, please. Next slide. Okay, so just to give you some numbers, total cases till now we are around 640,000 cases with around 8,400 deaths. Concerning the vaccination, as you can see, as a cumulative number, we are now around 52% of the population got their first dose. The second dose around 30%. And we just started a few days ago, I would say 10 days ago, with the third dose among the population, especially people who are at high risk. You know, we are a population, just to give you an idea, we are a population of around 5 million people. Okay, so those are our numbers for now. Next, please. Next. Okay, so we started our first COVID suspected case. It was a transport from the Syrian borders. It was on February 5, 2020. Actually, we had the possibility to make this transfer your way because Lebanese Red Cross and trained, and we had some contingency plans. Of course, not related to COVID because we didn't. Trained to deal with Ebola, and this gave us a big capacity, just some adaptation and be able to deal with COVID-19. First case, or our suspected case, was on. Next, please. Since the beginning, the Lebanese Red Cross was part of the National COVID-19 Preparedness Committee, in which you find all the ministries and the army and all the entities who are responsible in the country. Next, please. This is the preparedness committee. This meeting, as you can see, it's not in the middle of COVID because they are without any PPEs. So as I was saying, we have contingency plans with SOPs and training since the Ebola outbreak and in 2014, and even we had the PPEs, and that's why we was able to react immediately and to deal with patients suspected of COVID-19. Next, please. So phase one, let's see all the slides. Can next. We started with the medical coordination. For those who don't know, the Lebanese Red Cross works in Lebanon. He has EMS, the Emergency Medical Services. So we take care of accidents and we transport patients. We have also blood banks, disaster management unit, disaster risk reduction unit, medico-social department, psychological support. We actually do all what's related to health, and we are the national organization who is responsible of rescue and transportation of patients. So in phase one of COVID-19, we activated our medical coordination to identify suspected cases among patients we are transporting. And we were the only organization to transport patients who are suspected of having COVID-19. Of course, in parallel of that, we were a lot of awareness among the population to try to reduce the risk and to help people even shelter, because not everyone was able to be quarantined or to be supported while quarantined by food and medication and even PPEs. And we help also by PCR transportation, the specimens, we are transporting them from villages or from the region when they are done to central hospitals to be tested. Next, please. The system already exists, but we build it. We scaled it up quickly. We were doing those through our dispatch center. Every call was taken by a physician from the medical direction team and the quality improvement team to try to define if the patient is suspicious to have COVID-19 or not, to deal with it with him the right way. Next, please. We created, our dispatch, our hotline is 140, and we created another one, 1760, for non-emergency services. We implemented those services, home care services. We had medical teams with a physician, a nurse, a driver, to go and do home visits for patients who are suspected or who have COVID, to evaluate them at home. Because, as you know, as my colleague was mentioning before, the hospital was full and the healthcare system was overloaded. So we tried to help the healthcare system by giving care to people at their own home. We also help them we initiated a project to deliver oxygen machines for people who are COVID positive and who are stable and just need O2 supplementation, also to try to lower the burden on the hospital. And we supported the COVID-19 patients also with food, with hygiene kits and everything that we need. And even with quarantine centers, we implemented many quarantine centers. Next, please. Excuse me. Next. Okay. So to go towards the vaccination immediately, we had essentially vaccine awareness sessions. We had more than 100 sessions, and we reached more than 1,000 beneficiaries. Those sessions were really important. Next, please. we aim to explain for the people what is the COVID-19, how it's transmitted, how can we safe towards the COVID-19 virus, and to give them data about the vaccination. We explained about the vaccination, how does it work, what are the different kinds of vaccines, and of course we try to list the benefits and also the side effects. We try to convince people to get the vaccine. And also we help them by explaining the process of signing up and receiving the vaccine, because they have to go to the website and get registered there, and not everyone knows how to do that, and even not everyone has a smartphone or a tablet to do so. So we went door to door to outreach people and help them to be registered and follow up with them for the vaccination. And even now, at this stage, with we go and reach out and we keep calling people who were registered but didn't show up to be vaccinated. So in collaboration with the Ministry of Public Health, we call them. We try to find out why they didn't show up. We try to contact them and we try to help them. Sometimes we bring them with our ambulances if they are not able to move, or they have severe illnesses or something chronic problems. So we bring them even to the vaccine centers to get their vaccines. Next, please. And we initiated the online platforms as e-learning to try to have the maximum awareness. And what was of big importance, I think, that we initiated child-focused games. So it was games that will help kids know better the COVID and talk to them how to prevent, how to be safe with the pandemic. Actually, we reached 1,000 beneficiaries with the e-learning and more than 5,000 kids with the games. There was instructive games, and the kids enjoyed them and learned, I think, much of them. Next, please. Next slide, please. Vaccination center, of course, to be help to help like we should. We made a vaccination center. Our vaccination center is the largest center in Lebanon. We had the idea. We was looking for a place. We thought about an outdoor place, indoor place. Then we decided we wanted a big place and somewhere with good access, easy access. So we decided we had the idea to implement it in a shopping center, in a mall. So we have a mall in Beirut. We took a part of this mall and we made it a vaccine center. It was really a good idea because we could reach people who are coming to visit the mall to make shopping, where there were plenty places for their cars, and we even got the facilities from the management of the mall. So we had a big vaccination center, and it's run by coordination between the Lebanese Red Cross sectors and units. Essentially, the Faculty of Nursing Sciences, because the Lebanese Red Cross has a Faculty of Nursing Sciences. So we reach out our students, of course, to help us with registration issues, and our graduates who are the nurses, the practical nurses, to do the rest, to do the vaccination, the observation, and to help in the emergency rooms that were created there, and the pharmacy also. The medical direction of the Red Cross, of course, it supervises this activity, and the disaster management unit also, and of course the EMS. The EMS and the EMTs, the technicians, are always there with their support when needed. Next. So far, we in our center, 5,000 person. You see how it was evaluating. So it started in May. We had the peak in July. And then we are still keeping a good number relatively of people vaccinated in our center. As you can see in the picture, this is the shopping center, and this is our vaccination center inside of it. Next, please. So total vaccines starting June until today, 75,000. As you can see, 31,000 first shot, second shot, 44,000 approximately, and the third shot we just started with the third shot. Actually, as per today, the number is bigger, but we didn't exceed the 100 yet in our center. So mainly, we help to increase the vaccination rate by doing the awareness, by helping people get to the vaccination center if they cannot come, and by helping them register on the platform, and even offering them the technical the technical support, offering them. We are using our tablets, our phones to register them, and then call them or bring them to get the vaccination in our vaccination center. Next, please. Next, please. So I thank you again for inviting us, and I'll be ready to answer any question about our activity.
Thank you very much, Dr. Nasser, for this very detailed presentation. In Lebanon, which has suffered a lot in the past few years, and we are all in thoughts with you. We have questions about how you train the workers delivering the vaccines. Do the vaccinators come from hospital or the ministry, or do you have community health workers who have vaccination experience, or did you train them anew?
So they are registered nurses who work in the different hospitals. Of course, they are familiar with giving injections, but we gave them the necessary training with a coordination with the Ministry of Public Health. And as I mentioned, they are all the graduates of the Faculty of Nursing of the Lebanese Red Cross. Our team today is consists of around 90 nurses. Of course, not everyone comes every day because we didn't want them to leave their essential work, because we are in a crisis, and we are in shortage of health workers like nurses and doctors, because unfortunately, due to the crisis, our economic crisis, are leaving the country. So they already have the knowledge, and we trained them with the Ministry of Public Health to do the job like it should be.
Thanks a lot. We have a very tight agenda, and we only have 20 minutes left. So with your permission, we will move now to the final presentation of this session. And this presentation is from our colleague Yap Wei-on from the World Bank on public financial management with, for human resources for health. Over to you.
Yes, and just a slight correction, I'm actually a WHO consultant in this capacity, but yes, I do consulting for the World Bank as well. So good morning, good afternoon, good evening. My name is Dr. Yap Wee An, and I would like to share some emerging observations and insights related to the intersection between COVID-19 vaccination financing, particularly public financial management or PFM, and human resources for health or HRH. And this is based on an analysis of a small sample of Southeast Asia region member states. We have heard about the importance of expanding supply and also optimizing existing supply. The stories, particularly from Romania, are very compelling. Especially for countries which have not been able to invest in HRH before for a variety of reasons. I know the story about IMF presented earlier. In order to achieve vaccine equity, the question before us is, can PFM help? This analysis is structured according to the PFM framework, which is cited below. And the key issues at the intersection of PFM and health are how basically to optimally plan and reserve resources for COVID-19 vaccination, which is probably obvious to us that it's a very large health sector delivered intervention, and how to formulate these in a manner compatible with the existing health system without undue displacement of other priorities such as essential health services. These plans then need to be executed and delivered right at the front line. Resources need to reach people, financing needs to reach vaccinators, the right person, the right amount, the right way, and at the right time. Furthermore, to inform future budget planning and accountability, reporting on expenditures and outputs are critical. This is why this framework, I'm presenting it as a cycle. Let me also mention a disclaimer. These insights are based on a small and ongoing analysis of COVID-19 vaccination financing among Southeast Asia region member states. This is a very fast-paced pandemic. Probably said that a million times, or you've heard it a million times, yet early lessons and insights need to be shared in a timely manner. And so this analysis is not quite final and it's actually ongoing. And for this reason, I would ask you not to cite these findings yet. The first part of the PFM cycle is budget planning and formulation, including deriving cost estimations to inform budgeting. And this analysis found that there was very wide variation in the unit delivery costs across member states. In fact, there was a 15-fold difference between the lowest and highest COVID-19 vaccination unit, i.e. per person, delivery cost estimates. Why was this so? Well, as I mentioned, noting the limitations of making inferences from a small sample of member states, the variation in costs appear observationally to be driven by a few issues. The first one is of particular relevance to the topic today, is the content of what's being costed. Which cost categories did member states consider necessary to be included for resource mobilization beyond their existing health budgets? One important cost category is HRH. In general, member states with strong health systems did not include so many cost items, as they were presumably able to leverage existing capacity. However, countries with weak pre-existing health systems generally costed in large surge costs. In other words, health system contexts likely contributed to varying cost estimates. Countries which had already invested in their health systems, including HRH, faced smaller additional costs to reach the same level of capacity to deliver critical and emergency interventions. The second driver of variation is the methodologies used. There were a variety of methods used, but most of them based their estimates on existing immunization or EPI plans. But these unfortunately covered different target groups, and they generally occur during the regular delivery of MCH services. And the speed and scale is really on a totally different magnitude to COVID-19 vaccination. Unfortunately, member states did not appear to explicitly optimize delivery strategies to reduce financial and human resource needs. This important PFM function was not clearly leveraged. Next slide, please. One slide before this. Yes, but for many member states, plans have already been made. Can PFM still play a role beyond the planning stage to support HRH? Yes, and there are at least two areas in this next part of the PFM cycle, this next part, the budget execution and spending modalities part. Firstly, by expanding the supply of human resources, both in the government and non-government sector, by making better use of existing staff and potential new vaccinators. Second, by ensuring funds flow smoothly and quickly to frontline vaccinators so that they are compensated and incentivized to work expeditiously and have adequate resources to do so. For example, by ensuring that they are provided with or can purchase fuel and other needed supplies. In the longer run, but I will not have time to elaborate on this in greater detail, strong reporting and accountability will also be important to inform, justify, and optimize future resource plans. You can't plan your budget without planning human resources, and that is actually the third part of the PFM cycle. Next slide, please. Options to make greater use of public sector workers have already been described in earlier presentations, especially the presentation by Amani, for example. Payment and incentives to providers is a PFM function which supports this. And indeed, member states did describe or report the following interventions, which I'm going to describe. Firstly, changes were made to rules related to overtime claims to expand the limits on the maximum duration of overtime. And this allows existing HRH capacity to be expanded, if you like, at least in terms of hours, although there's obviously a risk of burnout. And as we heard so clearly from the narrative from Romania, this is also a human story. It's not just a matter of just increasing overtime limits. People may not be happy to work additional hours or to be shifted around. Second, special allowances analogous to risk allowances were also added to incentivize providers to vaccinate. And this can apply to existing human resource capacity, but it can also be used to bring in potential new vaccinators. Third, as this should be a two-scale intervention, it is critical for funds to flow smoothly without delay, or else frontline activities can get stuck for a lack of resources. Frontline workers generally need to report their expenses or hours to get reimbursed. This process can actually be onerous and in fact take quite a lot of their own times which could have been spent vaccinating. At least one member state specifically leveraged mobile phone technology to speed up this process of expense claims. Next slide, please. What was not reported by member states in this small sample but deserves discussion is a re-emphasis that really due to the speed and scale of vaccinations, and I look at the questions which were asked by people, which reminded me to add that there's also, by the way, you know, the COVID-19 pandemic itself, which is weighing in on the health system. So this means that the PFM system is heavily burdened with large volumes of expense claims, reports, authorizations for disbursement, transfers to subnational authorities or other entities. Existing PFM systems may have actually worked fine before, but the speed and scale needed now may warrant different or flexible rules, technology, as I mentioned, and additional financial management capacity. Vaccinators or those supporting vaccinator programs, not everybody who's involved in vaccination program is going to be the person injecting, right? There are roles for a whole team of people. And these people may be redeployed from other sectors, non-health sectors within the government. And this will require flexible procedures for training, temporary secondment, but also budgetary coordination across sectors. This is in addition to all the other aspects like the legal aspects mentioned in the Romanian example. Next slide, please. How about the private or non-governmental sector? How have member states used PFM to leverage this sector? Well, at least one member state reported repurposing an existing health administrator, like a health insurance entity, which is like a national health insurance entity, for example, to engage with the private sector to deliver COVID-19 vaccination services to a wider population than covered previously by that administrator. These entities have the capacity to enter into contracts, to verify outputs, to disperse payments, and they also have a pre-existing network of providers. So this expands the potential supply of vaccinators to the private or non-governmental sector, both for profit, and as you've seen in Lebanon, the non-profit sector, who can then make appropriate arrangements for quality assurance and training. And I'm very glad to see that people were asking about this very crucial aspect, training, how do you ensure that quality is preserved. Arrangements for engaging or contracting the private sector are generally based on verified outputs for each person vaccinated, rather than on inputs like salaries and travel allowances. The next slide. This actually helpfully reduces the PFM administrative overheads. You don't have so many, you don't have to tally up all the petrol, for example, or hours worked. You just need to know how many vaccinations were delivered to the quality and standard required. So this means expense reports are no longer needed. You do not need your private contractors to itemize and submit their expenses, as there's actually no need to impose rules for resource use by private providers, so long as outputs and the quality of outputs are verified. And this links actually to the third part of the cycle, which is expenditure reporting and accountability. Next slide, please, which is the concluding slide. What can countries do now in the PFM space to minimize HRH constraints? Now, let's be humble and say that this is not the silver bullet, just do some PFM thing and then your problem of HRH is solved. There are no real easy solutions in the short term. So let's be realistic about that. But I would suggest that member states, firstly, should conduct or update their cost and resource estimates comprehensively. And this should be done not just for resource mobilization per se. It should be done actually to optimize delivery strategies by exploring scenarios which reduce both costs and human resource needs. And also tell us the estimated footprint of vaccinations on the health systems more broadly, so you can have a sense of the risk of displacement of other essential health services. Secondly, evidence gained from expenditure reporting can actually be used to advocate for investments in human resources of health. So it's actually good to have good records. Remember also the first point made in this presentation that the unit costs for estimates for vaccine delivery appear to vary by the pre-existing strength and capacity of the health system. HRH is not just a sunk cost, but an investment for which dividend can be reaped. Next, flexible rules to speed up the flow of funds and disbursements, technological solutions, increased PFM capacity, and contracting out COVID-19 vaccination services based on outputs delivered and verified can also support the execution of COVID-19 vaccination. And with that, I'd like to thank you very much and look forward to questions. Thank you.
Thank you. Thank you very much for this extremely interesting presentation and the realization that the weakest systems are also those that require the higher cost for such capacity. In that spirit, do you think that one of the legacy of the pandemic is going to be a lasting increase in health workforce in most countries, and if yes, will it in particular be the case for the countries with the lowest UHC indexes?
Thanks, Patrick. I think like that's a billion-dollar question.
Yes.
And I'll just answer it based on just my own impressions. I don't really have strong evidence to back it up, but I would say that it depends on the policy choices that countries make now. It depends on what countries decide to do. It is an active process. I think there are some countries who will look at the situation and think we now have an economic crisis. Goodbye pandemic. We've vaccinated 50% of the population. We are just going to forget about thinking about this pandemic anymore. Let's move on to the rest of the sectors of society and develop it. And this opportunity to reform the health sector as a whole, to strengthen it for future pandemics, and even just to deal with increasing demographic and epidemiological shifts which are happening globally, climate change, etc., will be missed. But there are, and especially because I think human resources has taken a hit, right? Some people are ill, some human resource people would have got mental conditions because the huge workloads, and some have died even. But some people may have been inspired to enter this field because of the pandemic and its implications. But I think countries which make policy choices really to think that this shows clearly the importance of health. For example, I hope the IMF does not ever ask countries to cut down on their health workforce implicitly by cutting salaries. I really hope that doesn't happen again. So I really hope policy choices moving forward will actually strengthen human resources in the future. But I think it is a choice that countries face. It will not happen automatically. It takes leadership.
Thank you. We have only 5 minutes left, and the organizers had also planned to conduct a little poll. Should I turn to the co-organizer just to indicate to the participants how they should complete this poll?
Patrick, while people are answering the poll, if I can take the option of posing a question to you from one of our Q&A, will the health systems and response pillar of Act A include this in their strategic direction and push these needs and gaps towards governments so that they look at this for investment?
Yes, I mean the question. My question was not innocent. It is obviously one of the major issues, and it is a rate limiting factor for all the activities. The human resources will determine the pace at which vaccinations can take place, and they also determine what can be delivered in terms of diagnostic and care and the treatment for COVID-19, while trying to maintain the other essential health services. So that is spot on. That is spot on, and I think it was very well articulated in your presentation initially. And the countries are facing exactly those tough decisions, and very often, if they have limited human resources, they will have to prioritize the group of population who will be receiving vaccination, so that those who have the highest risk can benefit from the protection.
Thank you for that. And I know it's unusual to pose a question to the moderator, but given your role, you are uniquely posed. I'll just read the introduction poll so that the translators can offer this to those who are listening in French or Spanish. The two questions are, does your country have enough health workers to respond to COVID-19, maintain essential health services, and deliver COVID-19 vaccines? The answers are yes, no, maybe, and I don't know. The second question is, how are COVID-19 vaccines being delivered in your country? You can choose one: public health workforce, private providers, pharmacies, civil society organizations, Red Cross or Red Crescent. I don't know. Vaccines have not been available in sufficient quantity. We'll give one more minute for responses, and then we'll look at what these poll responses are. Thank you.
Great. Maybe we had one more question for Jaap. There was I'm sorry. So as a question, while expanding working hours limits, redeployment could be feasible in situation of emergency for few weeks, months. How this can apply without impairing health worker labor's right with the third situation becoming chronic, and the health workforce need over several years primary vaccination and booster dose spanned for months. You have any comments on this?
Just to chime in sympathy, I think a lot of us, including myself, we really have been struggling during this pandemic to really put in additional hours. And I think we are just one of millions of health workers. And this is not sustainable. I totally agree. And I would think that people do need to make policy choices to do so in a way which I think is our Romanian colleagues said, don't just aim for 95% capacity being used as the gold standard, right? Because then when an emergency happens, what do you do? You should not be running at like at your maximum, right? Or close to your maximum just in routine delivery conditions.
Absolutely. So do we have the poll results? So it appears that among participants, a similar proportion of countries seem to have enough or not enough of health worker to maintain essential health services, and 17% are saying maybe. The second question, how are COVID-19 vaccines being delivered in your country? Primarily, a vast majority is 83% through the public health workforce. Private providers seem to correspond to a relatively small proportion. And pharmacies are the other option. So I think this gives us a very interesting picture of the countries who participate in this seminar, because the situation is probably quite different in some high-income countries. With this, I think we have reached the end of the seminar. So obviously, we are reaching a stage which is going to be very important for equity in access to vaccines, since COVAX is telling us that in the coming weeks, there will be a massive procurement of vaccines to low and middle income countries. Obviously, we are all holding our breath to see how adequately those vaccines will be put to use, and there are a number of health systems issues that will limit the ability of countries to utilize those vaccines promptly and in an equitable fashion, and certainly the availability of health workforce is one of them. I think we all understand that health workforce cannot be generated out of thin air, and creating a surge capacity is probably also proportional to what is the current status of the national health workforce. Countries that have made drastic reductions, like was the case of Romania, have faced difficulties, but have found solutions. Being able to provide 100,000 doses of vaccines per day is absolutely remarkable. Hopefully, also the work which will be done for COVID-19 vaccination will leave a legacy for the other immunization programs, one of the many essential health services which has been affected by the pandemic. Thank you very much, colleagues. Thanks to the organizers. Special thanks to the 4 presenters who had very clear presentations, well managed also in their timing. Recording from the session will be available in English, French, and Spanish, and the next session will take place Wednesday next week on COVID-19 vaccination financing in the Southeast Asian region. Thank you very much. The questions that have not been answered during the session will be shared with the technical experts, answered and shared via email.